Welcome to this presentation on the Medicare program. This is the first of three presentations designed to introduce you to the basics of governmental programs to provide coverage for the healthcare of older adults, of people with disadvantaged economic circumstances and disabilities, and people who are facing the end of life. And those are the Medicare program, the Medicaid program, and the Medicare Hospice benefit. My name is Jim Pacala. I am a family physician and a geriatrician, and I will remind you that I am not a health economist.
The objective of this presentation is to understand the basic structure of Medicare. I'm going to go through the different parts of Medicare. And the important part then is to try to get a sense of what this means for the enrollees or the patients, for the providers, those are the doctors and the hospital systems and healthcare systems providing care, and for the payers, those are the entities that are paying for care. This presentation will be the longest of the three presentations by quite a bit, so hang with me. I have one financial disclosure to air out, and that is through an accident of history. The chair of the Department of Family Medicine and Community Health at the University of Minnesota is also, by law, the chairman of the board of UCare, which is the fourth largest health insurance system, health insurer in the state of Minnesota. And UCare offers a Medicare Advantage product, and I will be discussing Medicare Advantage products later on in this presentation. So I'm going to go through, first of all, what is known as traditional fee-for-service Medicare, that's parts A and part B. Follow that up with a discussion of Medicare Advantage, that is known as part C Medicare. And then finally, we will finish up with prescription drug coverage, which is part D. This is a picture of President Lyndon Johnson in 1965 signing the Medicare law into service. And this was really an enormous piece of legislation and quite a legislative victory for the Johnson administration. Now, does anybody recognize this smiling gentleman in the back? His name is Hubert Humphrey. He was the vice president of the United States at the time and a former senator from Minnesota. So Medicare is an insurance program. It's an insurance program run by the federal government and is housed in the Centers for Medicare and Medicaid Services, also known as CMS. And it has these two parts. Part A is an automatic, anybody who has been a citizen of the United States and worked and paid taxes is automatically enrolled in Part A. Part B is voluntary, but about 98% of the people who qualify for Part A will enroll in Part B as well. And that is financed through a small Part B premium. Again, this is a federal program. It's run by CMS. CMS is part of the executive branch of our government. So ultimately, it is under the direction of the White House. Now, let's talk about traditional fee-for-service Medicare. Here's the basic structure. And along the left-hand side of this diagram, you'll see what it means for the patient. In the middle, what it means for the provider. Those are the doctors and other healthcare professionals providing care, as well as hospitals and clinics. And then in the bottom is the payer, who in this case is CMS. And I'm going to go through the order of events that occurs when somebody is enrolled in Medicare. So the first order is that a patient qualifies for Part A through paying taxes, and then usually enrolls in Part B and pays the premium in Part B. All of that money goes to CMS. Then the second event that occurs is that the patient seeks medical care. So they get a cold, they get sick, they want to go see their doctor, they have a bad accident, they go to the emergency room and a hospital, and they get care. And the third event is that then that provider provides care for that patient. and whether that's a medical service or a surgery or whatnot. The fourth event then that occurs is after that has occurred, that service has occurred, the provider submits a claim for their services to CMS, and then CMS reimburses the provider, the doctors, the clinic, the hospital, the emergency room, whatever, for the services that they've provided. The key take home here is that the payment for the provider follows the service. The service comes first, and then the provider gets paid. Once again, Part A covers hospital and post-hospital inpatient care, and Part B is primarily for outpatient care. Here is a little more detail on what these things provide. I'm not going to read this slide, but you can take a look at it yourself. The Part A is much more comprehensive in terms of its coverage than Part B. Part B is usually partial coverage for outpatient services. Now, what doesn't traditional fee-for-service Medicare cover? Frequently cited are hearing aids and eyeglasses, which can be quite expensive, but the most expensive ticket that Medicare does not cover is long-term care. So this is nursing home care, extended stay in nursing home or other types of chronic care facilities. Medicare, when it was first signed into law in 1965, did not cover outpatient medications. Now there's an optional, there's an option for those who want it to enroll in a Part D plan, and that's been in the case since 2006, and I'll be talking about that in a few minutes. Also, Medicare was never designed originally to cover preventive care and preventive physicals. Since 2010, that has been covered by Medicare, and it's something known as the Medicare Wellness Exam. That was since 2010 because that was written into the Affordable Care Act of 2010 in the Obama administration. Now, it's important to understand from the patient's point of view what the out-of-pocket costs are. Remember, Medicare is an insurance program and pays for care, but there are out-of-pocket costs for the enrollees. The first is the premium. That's the amount you pay for your insurance coverage. Second is what's called co-insurance, or your percentage of what the insurance doesn't cover. So Part B frequently covers 80% of outpatient services. That means that you're responsible for an additional 20%. Then there's a copay. A copay is a flat fee that you pay up front each time you engage a specific element of healthcare. So copays are often used for office visits or visits to the emergency room. You go there, you have to pay a certain amount. And that amount is the same every time you engage that service. And then finally, there's a deductible. And the deductible is the amount of money that you pay for the initial costs of your healthcare. It's kind of like collision in your auto insurance. It's what you pay up front. And after you pay that deductible, then the rest of the insurance kicks in. Now, here's just an idea of what Medicare rates are. The Part A deductible, in other words, if you get admitted to the hospital, that is covered by Part A, and you'll be responsible for the first $1,484 of that hospital stay. After that, 100% coverage kicks in under Part A. The Part B monthly premium in 2021 is $148 per month. That is increased if you make more than $88,000 in a year, and it escalates the more you make, the higher your monthly premium. And then the Part B deductible is actually fairly modest. It's $203, after which all of the Part B coverage options will kick in. So again, this is the basic outline of traditional fee-for-service Medicare insurance. Again, the payment follows the service, and the payment to the provider is based on the amount of service that's provided and the intensity of the service provided. So for doctors, under a fee-for-service system, the more care that is provided, the more they do, the more they make. Now, if you're a patient and you enroll in traditional fee-for-service Parts A and B, there will be services that are not covered by them. And so if you want those services covered, you can also elect to take out what's known as a supplemental insurance. And that is a payment to CMS. If you do so, it's called Medigap, or another insurance company. And that is a supplemental insurance cover. So you can take out this supplemental insurance or Medigap policy to pay for some of the costs that are not covered by traditional Medicare Parts A and B. And these insurance policies have 10 different levels. The basic level will run you about $70 a month. The fanciest and most extensive coverage level runs about $750 a month. And they all vary by the amount of coinsurance, copays, and deductibles. So this is the end of part one. And the summary here is that in traditional fee-for-service Medicare, Part A is automatic, Part B voluntary. It's a fee-for-service payment to the providers. It is administered, it is a federal program administered by the federal government. And if you want to, you can elect to get supplemental insurance. Now let's move on to the second part of this presentation, which is on Medicare Advantage, which is also known as Part C of Medicare. Now, the way Medicare Advantage works is that a group of patients, a population of patients, will decide that instead of enrolling in traditional Medicare, they will enroll in a Medicare Advantage health plan, which is at the bottom of this slide. And they still pay into Medicare through their taxes, and that money goes to CMS, but CMS acts as an intermediary in terms of being a payer, because what happens then is that CMS will provide an amount of money to that MA health plan, and it's capitated. In other words, it's upfront money based on the number of patients enrolled in that MA health plan. And it is also adjusted somewhat on their health and complexity level. So that occurs first. Then what happens is that those patients engage the healthcare system in that MA health plan. So they engage primary care and specialty care that is in the network of that Medicare Advantage plan. And then that Medicare Advantage health plan reimburses the primary and specialty care and hospitals and so forth, providers of care, using the funds that it has received from CMS to do so through those capitation payments. Now, what you'll see then is that these MA health plans, which are often run by insurance carriers, will try to entice Medicare enrollees into joining their plan. The more people that join their MA plan, the higher the capitation payments that they will receive from CMS. So you'll see ads in the paper and on TV and so forth of usually of seniors having a ball. They're healthy and they're having a great time because they're enrolled in this MA health plan. So again, this is how it works. CMS provides the payment to an Advantage plan. It's based on the number and their health status. Then the Advantage plan has to take all of that money and provide all of the medical care to those patients. So they have to cover all the services that would have been covered under traditional Medicare Parts A and B. And then they can decide to add services that they want to cover as well. Now, this graphic shows you that the Medicare Advantage plan system has grown dramatically over the past couple of decades. And in Minnesota, you'll see that Minnesota has among the highest prevalence of seniors deciding to enroll in a Medicare Advantage plan. Now, why is this? why are there MA health plans and why are they becoming increasingly popular? Well, here's one reason. This is a figure that is in 2020, the national health expenditure per capita on Medicare patients cost $11,500 per Medicare enrollee to take care of them per year. This causes the federal government and the people that are responsible for financing the Medicare system to have a reaction like this. So what does the federal government do? They created this MA health plan option. And what's in it for them? Well, what they do is they take that capitation amount and they calculate what they think they would have spent on those patients in traditional Medicare Parts A and B, and then they discount it. They provide less in their capitation payments to the Medicare Advantage plan. In other words, they are saving money through transferring that capitation payment and the financial risk onto the MA health plan rather than incurring it themselves. Now, what's in it for the MA plan? Why did the Medicare Advantage plans do this? Well, they get these capitation payments, which are on the order of $900 to $1,200 per member per month from CMS. And then they have all of that income. And if they're more efficient than the federal government, if they're more efficient and can set up efficient care strategies that will take care of those patients for less money than would have occurred given the capitation payments, they make money as well. So it is a win-win economically for CMS and for the MA plan if they can make it work. Now, what's in it for the patients? Well, what's in it for the patients is that they can actually go online and choose the MA plan that they feel best fits their needs. Now, doing that means that they go out and they have to choose from among a dizzying array of MA plans that are offered, and they all vary by their premiums, their copays, their deductibles, the network, and so forth. But most MA plans will offer coverage of extra services that are not covered in traditional Parts A and B. The other thing that patients can do is they can add a Part D plan, a Part D coverage option. In other words, get prescription drug coverage through their Medicare Advantage plan, and all that's taken care of in one entity. So to summarize Part C of Medicare, the way it works is that the patients enroll in a specific plan. They are guaranteed the same benefits as they would get if they were in fee-for-service Medicare, but the Medicare Advantage program often provides extra benefits, and it's administered by health plans who have taken on the financial risk by receiving capitation payments from CMS. And now let's finally finish up here with Part D, which is prescription drug coverage. Now recall our traditional fee-for-service system here and the way that works. And then, pardon me, let's focus on the right-hand side of this. And we talked about supplemental or Medigap policies that cover services that aren't covered by Parts A and B. Now, one of those is not prescription drugs, but due to Part D, you can add a Part D plan and get coverage for prescription drugs through some legislation that was passed by the federal government in 2003. Similarly, for a Medicare Advantage system, which we went through, you can then choose an MA health plan that also offers Part D. And if you do that, you pay that premium for the Part D plan. And then that coverage, that drug coverage, will be administered and paid for by the Medicare Advantage plan. And again, this was enacted in 2003 under the George W. Bush administration, and it went into effect in 2006.
Just a couple of things about Part D plans. Like MA plans, there really is a dizzying array of different Part D plans offered, and they all vary by the level of premiums, the copays, deductibles, and so forth. There's also something called tiering in many of these plans, where they divide the drugs in their formularies into 4 different tiers. Tier 1 is usually the cheapest tier, but if you require a tier 4 drug, which is a very expensive drug, then the Part D plan may cover it or it may not. And then finally, there's something called the coverage gap, which has also been referred to historically as the donut hole. And that is that if you use a lot of drugs and spend a lot of money on prescription medications, there's a level at which coverage stops in Part D plans. And in 2020, that was about $4,100. So the Part D plan would provide you with some coverage on your prescription medications when you spend up to $4,100. If you exceed $4,100 above that, then the Part D plan doesn't cover anything. And so you're responsible out of pocket for all of those costs above $4,100 until you reach a second threshold, and it's usually just over $6,000, after which the Part D plan will pay for any extra costs above that upper ceiling. So there's this approximately $2,000 coverage gap for folks who spend an awful lot on prescription medications.
So the summary of the Part D is that it can be added as a separate plan or as part of a Medicare Advantage plan. A huge array of cost-sharing tactics are usually employed by Part D plans with varying amounts of premiums, deductibles, copays, tiering, etc. And it's administered by health plans that receive capitation payments from CMS or in standalone coverage plans. So that is the end of the presentation on Medicare. I hope you've enjoyed it. What we're going to do in the small group cases, first of all, you need to view the other 2 presentations on Medicaid and the Medicare Hospice benefit. But then in small group, you're going to really focus in on the Medicare program, and you're going to explore it a little bit further from the perspectives of the patient, the provider, and the payer. Thanks very much for listening.